Alrighty, thank you everyone for joining us. I'm gonna start with a brief introduction to today's webinar and sort of background about the center, and sort of frame it in context of our last session in December. And as I know, some people come in, so you may miss part of the introduction, but this is being recorded and will be posted to a later date. So, hi everyone, thank you all for joining us this afternoon for our January installment of the Massachusetts AI and Technology Center's monthly webinar series. My name is David Paquette, and I am the Associate Director of Research here at Mass AITC. Last month, we highlighted work from Dr. Gong Wang leveraging large language models to help older adults be safer and more educated about SMS phishing. And a recording of that webinar is available directly on the YouTube and linked from our website if you missed it. In that session, he discussed development of an AI agent, which included older adults and the design and validation of that algorithm. But this is often not the case more broadly. In today's session, our speaker will provide a landscape view of the current status entitled Advancing Fair and Effective AI for Older Adults. So without further ado, it's my great pleasure to present today's speaker, Lucy-Orr-Ewing. Lucy is the Director of Strategy and Policy for the Coalition for Health AI, which is also known as CHAI, not to be confused with, or maybe to be confused with chai lattes. And she's been with the organization since 2024, coming on board as the inaugural Chief of Staff and Head of Policy at CHAI. At CHAI, she leads policy engagement both at the state and federal levels and oversees the organization's research portfolio, including projects supported by the SCAN Foundation and the McGovern Foundation. Prior to her role at CHAI, Lucy was a Harkness Fellow at Stanford Medicine, where she worked with I know with a chief data scientist for Stanford Healthcare, Dr. Nigam Shah. I think she was advised by another Shah, Nivan Shah. And as a Harkness Fellow, she helped author a systematic review in JAMA of the testing and evaluation of healthcare applications of large language models. That was a Research of the Year Roundup awardee. Prior to her Harkness Fellowship, Lucy was Chief of Staff of the UK's National Health Service, as well as Head of Strategy for the Federated Data Platform. At the NHS, she convened more than 200 portfolios of work, including into one strategy, the Digital Health and Care Plan, and delivered the NHS first Health Tech Summit, amongst her other accomplishments. She completed her undergraduate education in classics, I think it goes to show that the background can inform. So I think she comes with a different perspective than a lot of us. And she's an active advocate of digital health and its potential to alleviate financial and capacity pressures and deliver affordable, equitable access to care. She's particularly interested in improving collaboration between the public and private sector and is committed to acting policy and behavioral change for innovation to have its greatest impact. And so today she's going to talk about her work that was funded by SCAN Foundation, sort of dipping and sort of taking her policy, card-carrying policy specs into older adult care and technology. So I'm going to stop my share, and Lucy, you can take the stage and share your slides and go from there.
Awesome. Thank you so much, David. For anyone who knows anyone who's British, a long intro like that is like absolute torture for anyone. So I hated that. But thank you very much for the introduction. And thank you for having me here. I'm really, really looking forward to meeting you all. You know, I really want this. We've got like a full hour, if you can stay that long. So I want to talk a little bit, but also want to hear from you guys. And I've seen Lily in the audience, which is wonderful. So great to see you, Lily. I'm sharing my screen so I can't see you so much, but thank you for coming and for participating in this project that I'm going to talk about. I want to hear about your reflections and thoughts as well. But anyway, I'm Lucy, Director of Strategy and Policy for CHAI. For those who don't know CHAI, I'm going to do a little bit of like a primer on CHAI, kind of some of the problems we're trying to solve within CHAI, and then as an example of something that we've been thinking about, talk a little bit about the research with older adults. And yeah, really grateful for the opportunity to have done the research and to talk to you about it, and really hope that this is a thread that I can pull on for a lot longer, because older adults are consistently underserved, especially within digital health and AI, and with an ever-growing population of older adults, I think it's more important than ever to start fixing some of those issues. So grateful to hear from all of you who are kind of battling in the space as well. So, Chai was founded in the pandemic. It's been around for a couple of years now, and it was really, founded as a response to not having a consensus definition of what responsible AI truly looks like. Everyone says trustworthy AI, responsible AI, but what does that really mean at a technical level from, development, deployment, and now monitoring of AI? AI is a constantly evolving technology that's not a static product. So how can we develop kind of governance processes to make sure that you are continuously monitoring something that is like highly dynamic and evolving? And so we're founded on this thesis, and I was very lucky to be at Stanford at the time, who was one of the founding health systems. And so, right place, right time came on to join Chai, but it was founded by Stanford, Mayo, Duke, John Hopkins, Amazon, Microsoft, Google. We sort of came together with this sort of coalition to begin with of leading health systems, leading tech companies who were building for health systems, all with this understanding of that we saw in the pandemic what collaboration looked like in between stakeholder groups. How can we apply that for AI to have truly its best shot at improving access, lowering cost, and improving outcomes for care? We are now, I think, the largest health AI community on the planet, although happy to be challenged on that. We have around 5,500 actively engaged members, and they probably represent around 3,500 organizations. And we really try and get as diverse a stakeholder group as possible involved in Chai so that we can develop consensus across, the broader spectrum of society that we can manage. We have several professional organizations, associations. We have, I think it's up to 300 actually now, health systems, obviously the academic medical centers, but also the more rural community health clinics as well, and many, many startups who are helping us to develop this. I only flash this up just in case, there's ground that's in any reality. Maybe some of you work for a health system, maybe you are a patient of one of these health systems. I think MGH is on here. I don't actually know, but maybe. And yes, Mass General Brigham, there we go. And yeah, just some really amazing names on this page who came together to kind of found Chai as a nonprofit. And I wanted to touch a little bit about like how we develop our work and what we're really there for. So I mentioned that we were founded on this thesis that we didn't really understand what responsible AI is, or what it looks like at a technical level. And so what we've been doing is convening many of those stakeholder groups that I've mentioned into work groups. We meet once a week in these work groups. There are 20 work groups going at any one time. And it's really about like convening stakeholder groups together to try and sort of get closest to the answer with as many people as we can. And then what we do is, we talk, we listen, we write, and we try and develop in our second pillar materials, frameworks, guidelines, whatever the kind of focus of the use case group is. We try and kind of develop materials and tools that you can actually use very practically. I'm not medical. I hope you heard that in my very long introduction. Not medically trained. I'm not a computer scientist. We're very practical people at Chai. We like doing things that make it the easy thing to do rather than just the right thing to do. And then once we've sort of all agreed on what best practice looks like, we then try and point people to partners that we think are actually operationalizing that best practice. So let's say, we're looking at an AI governance best practice. We might select or point to, 20 governance platforms that are actually, delivering this best practice of AI governance. And that's all in our sort of vein of trying to be as practical and helpful as possible. The last thing people need is just like a 200-page PDF document on like what best practices. They need like a company that they can procure or a process that they can kind of adopt that is like much more, I'd say, useful. And then after that, we try and educate folks on what we're doing. So we've developed literacy programs for nurses or family physicians, or micro-credentialing courses that people can take in their spare time to try and understand a bit more about this space. So I would say that captures most of the things that we're doing within Chai, but we get kind of pulled into all sorts of conversations. So I want to go back to this concept of like, what does it truly mean to be like delivering or deploying or developing responsible AI? And so when we first started Chai, we came together with, several hundred um, people before Chai was really a company, and we tried to define what responsible AI looks like in the terms of principles. And so we came up with these principles, and like, you'll see these types of principles kind of bandied around. There was like the FAVES principles from the federal government. This is like our version: usefulness, fairness, safety, transparency, security, and privacy. And we all agreed upon those as being the core principles of responsible AI. And I just think it's important to kind of think of those as the framing of everything that we do within Chai. So if we develop tools and resources, they all kind of marry up to these principles to try and kind of make these better understood. And so if you think about those five principles, we try and apply them to specific use cases. So what does it mean to, you might have gone to the doctor, you might have been speaking to your doctor, and in the background, there might have been an AI ambient scribe. If you don't know what that means, it just basically means a kind of, think of it as a sort of smart microphone that is listening to what you're saying to your doctor or nurse, and writing down what they're hearing directly into your electronic health record. And then the doctor can go in and, make some amendments if they've misheard something. But that's essentially what an ambient scribe is. So I'm just using it as an example. It's probably the best known example. So we try and get together as a work group to define what responsible AI principles. So like, how is an ambient scribe useful? What are some of the metrics for measuring how useful that is? How is it transparent about maybe how it's been listening to you, who it's been trained on, etc. How do they keep your data secure? Like all those things that might form or constitute a kind of test and evaluation framework for how you would test these AI use cases for these principles of responsible AI. So that's kind of like and then we'll also publish best practice. So what does good look like within all those use case categories? And I think then we publish everything on GitHub, and other kind of open source uses, so that folks can, everything we do at Chai is open source and free to use. And I think especially interesting when you start getting into the space of like prior authorization, because if, an insurance company, it's like a highly, I guess, like anxiety inducing use of AI. There's plenty of literature out there. I'd really recommend people to go look at it, to say that actually a lot of insurance companies use AI to kind of automatically deny care on the basis of race. And there's been, horrible horror stories about that. And so I think just really making sure that, fairness as a principle is really adhered to when it comes to testing different prior authorization, AI use cases, as it's like more important than ever when that actually impacts care and coverage. And then so I'll just touch on a few examples. Happy to answer questions if they come in on kind of some of the focus groups. Um, yes, so sorry, I think Preeti, you just come into things. So security and privacy, I actually think of that more as in like sort of from a data perspective. So how secure and like from a cybersecurity angle is a solution. Like what are their kind of data use agreements? Like how do they, manage your data? Do they manage your data at rest? Do they have like encrypted technology around that data? That's more what we mean about that. Whereas safety is like, is it actually safe to use as an AI? Does it impact a patient's safety? Does it tell a patient to go and, here's how to, harm yourself or something? That's quite different to kind of security in terms of how they use your data. So it's just a slightly different term, but relating to kind of, I guess, the impact of the AI versus, how they're doing data use. And so again, I'm just touching on a few work groups, cross-cutting ones. So I manage the policy work group. Anyone is welcome if they want to come and join. We have about 150 people in there. I bring in state legislature from California or Utah, or policy experts from federal government to come and talk to people. And really, it's just about like, if you take nothing else away from what Chai is, I think we just believe in like the power of the community to try and figure out this like highly dynamic, highly, exciting opportunity that AI presents, but also like there's plenty of things to grapple with to make before we'd really trust it. I really think we're kind of we're sort of founded on the basis that like AI is inherently quite untrustworthy. If it was left to its own devices, it might be, um, not necessarily trained on representative data and therefore might, you know, uh, deliver outputs that are relatively unsafe or perhaps unfair to certain people. So Chai really is like about how to promote kind of fairness and safety within AI so that people can actually trust it and use it and actually see some of the benefits of AI. And I can go into any detail on any of this, but just try and be mindful of the time. Um, Okay, so I just want to touch again a little bit on like our processes because I think some people think we're like an HL7, which is a partner of ours. And if you know HL7, they're a kind of data interoperability standards company. And HL7 are like a 100% agreement type of coalition in that like, and they are actually accredited by ANSI, ANSI accredited standards development company. And they have quite a different process for developing like standards. Chai is kind of because we believe AI is moving so quickly, we are like the industry standard or industry leading standard at a point in time. And we believe like that it would be better to, do things properly, do things seriously in terms of collecting feedback, but actually get something out and then iterated upon in the open source community sooner, rather than actually go through the formal process. Because by the time you've gone through the formal process, it might be 6 months, might be a year, it's kind of too late. Like people need things now. So we primarily convene people from different groups within Chai. Some people are paying members, as in founding partners. Some people are like patient advocacy groups who don't pay to be there, but they're very much like being convened in the same groups. We're then developing materials. They might be best practice guidance or T&E framework that I mentioned. We might define the best way of testing and evaluating these AI use cases for use as a patient or use as a health system. And then we, iterate this with consensus around the work groups, and then we'll share publicly. So we're kind of continually in this process of convening, developing, defining, iterating, and sharing. Like that's kind of, how Chai works. And I think, like, if you try and think in your daily life, what are things that you use that you think have been through an element of quality assurance? Like, you know, think about the car that you drive to work every day. Of course, you have some level of confidence that this has been through some level of quality assurance. So the kind of crash dummy tests where they measure, the surviving rate of, the crash dummy at different mileage per hour, or perhaps like the light bulb that you put in your child's bedroom. Like you have confidence that that has been tested in a lab or in a facility, which is making sure that kind of different wattage doesn't mean that the, light bulb blows up at any stage. So, like just think about that. Like after this is like, what level of quality assurance has this been through? And why does that not exist for AI? There isn't like an independent lab that is kind of set up to do the quality assurance testing. So we believe that like as customers, you should actually have the wherewithal or the materials or resources to actually do that quality assurance. And so, in the context of like health systems, doctors and nurses are still wholly liable for AI. If something goes wrong with an AI or it's found to be discriminatory, it's still healthcare practitioners' kind of liability to sort of bear. And so they want to be really sure that like the tools that they're using, the AI that they're using, is actually, of a certain quality. So what Chai does is we've developed kind of quality assurance standards. And we also believe that there are kind of on that quality assurance spectrum, there's like several, areas of that. There's like actually doing the testing and validation to make sure that that AI is, safe. There's the kind of governing aspect of it to make sure, once you've tested it, how do you continually govern the AI to make sure that it remains safe after you've deployed it? Because post-deployment, is a different thing. And also as a health system, have you got the enabling infrastructure for AI to actually perform? Like, does it have access to great data? And so we're kind of thinking about that on a spectrum and like delivering and writing standards and quality assurance, as well as pointing to folks who are actually doing these tools. So we're actually building this governance platform that is in beta testing, or as Americans say, beta testing. No one knows what I mean when I say beta, but yeah, so beta testing. Um, and we want to get to a point that like almost if you are a customer of AI, you're deploying it maybe in your health system or your care plan, that you have a like guidance for how to do that, governance and testing, but also you have available platforms that are all kind of competing with each other on prices and features so that you feel like you've got kind of choices to actually deploy this AI tool with good confidence that it's been through the right processes to make sure it actually works. So this will be going live in the next couple of months, but you'll be able to log in, you may be able to even like input a use case, input the type of data that you're wanting to govern. Maybe it's a chronic disease management AI, maybe it's a sepsis risk model or something. And then it would maybe like spit out a few examples of different governance platforms. Maybe it includes some prices, etc. And you could then like request a consultation through this hub. And if you think that's kind of what Chai is trying to build, it's almost like a sort of industry to industry best practice platform that you can sort of um, have access to, I guess, like more information than what is currently out there. And just to say, like before Chai existed, health systems are just completely on their own. So whatever there's no federal regulation on how to govern AI yet. There might be. But so they're just kind of figuring out this process on their own, or maybe there's been a state bill about it or something. But they're like it's we're trying to kind of bring people together to try and learn from each other. So that's something that we're developing, which is exciting. And the second thing that you might have heard of through us is a model card. So just like when you go to the grocery store and you're looking on the back of the soup can and it has, carbohydrates and proteins and fiber, and you can make a kind of informed decision about the type of food that you want to eat depending on your circumstances. We think again there should be a process similar when you're using AI or procuring AI if you're a procurer of AI. And also as a patient, like, do I understand these things? And we're doing a lot of patient education alongside this. So if an AI is being used on me, who has developed this AI? Is it a nefarious company that I don't really trust or like? Or have they been funded by a, nasty, I don't know, billionaire based in wherever? Like you kind of just like, is that information available to you as a patient? Like we know. And so therefore you're not going to trust AI if you don't have that patient available. And this comes back to that responsible AI principle of transparency. And so we've developed this model card, which has the principles of responsible AI that I initially mentioned, usefulness, fairness, etc., embedded into this model card with loads of information on it that vendors, AI companies are filling out as we speak. And by the way, we're not the only ones to have invented the model card. Like lots of, like Google has one, IBM has one, plenty of kind of companies have believe in this concept. This is just one that Shai has developed with our community, so it seems to be very well adopted. And I'd say like several hundred AI companies have filled out a model card, and they're sharing it with their customers. And we're really excited about that. We hear actually it was UMass itself. I think it was Liz Garwood. I don't know if anyone knows her, but Liz was saying like up until this point, we would just get a pitch deck from an AI company that would say like have all these kind of snazzy visuals, but it told me nothing about like who has it been trained on, like known risk limitations, known biases, what is my like clinical risk score that I can give it. Like they had no information to actually make an informed decision on whether or not they wanted to use this AI company. And she was like, she'd sent us a note, and then she's somewhere on our website with a quote on it saying like, this is game changing. I now feel so much more confident in develop in procuring this AI because I can see way more about it. I have metrics, I have, background information. And so just trying to like shift the market. This is all, by the way, free to use, and everyone's been downloading it for free. And there's not really too much of an incentive other than that, like, might get you procured quicker for a vendor, and it might make you understand the AI and kind of increase your trust in the tool if you're a customer. But really, I think our community mainly joins Chai and sort of fills this out because they believe that this is like where the market should be heading. And so we're just the private sector, industry-led sort of standard for responsible AI. And so at the moment, this model card is a great example of, a tool that is free to use, no regulatory incentive to do so, but folks are using it at a huge kind of adoption rates just because it's kind of the right thing to do and it's easy. And so, because there's several hundred of these model cards being filled out, we've decided to kind of collect them all back in and, display them on a registry so that if you are a health system or you're a payer or plan and you want to reimburse an ambient scribe, let's say, you can filter by the use case for ambient scribes and actually compare all of these different elements. And maybe you've got Hispanic speaking population and or a Chinese speaking population, and you want to filter by some of the known risks because this ambient scribe has never been trained on, Spanish accents or something. Then, you might like that. That's the type of like in the same way as like an Amazon platform, you can like filter by different use cases and look at the reviews. And, we're trying to build a kind of similar system for health AI so that as a patient or as a customer, you can make more informed decisions about the AI that you're using. And yeah, there's a little bit more about some of the things that you might have known us for. We've built risk classification frameworks, literacy programs, model bills, quality assurance resources, applied model cards. This is all, by the way, built by our community. There is 5 people that work for Chai, and we would have a very tall order in trying to do all this by ourselves. So it is really just a reflection on what the community wants and needs, and they really help us develop these materials. So yeah, happy to go into that in more detail. Before I kind of go into the research, I'm just going to stop for 1 second because I literally haven't drawn breath and I don't know if there are anyone with their hands up because I can't see. But if anyone has any questions on anything I've just covered, let me know. Otherwise, I will dive into the research specific aspect of this. I actually can't see anyone, so I don't know if I'm going to look to David and Suzanne to call people out if there's anyone who wants to say anything, but otherwise I'll carry on. Okay.
I think there's a question in chat. Um, can you differentiate safety with security and privacy principles? Do these
Oh
relate to
yeah,
different
I already covered that, but I will happy go over that again. Preeti, did you hear the answer that I gave earlier?
Yes, I did. Thank you.
Yeah. Okay. It was just to mean, I guess, safety in terms of like, does the AI produce like harmful content or like unsafe content versus like security and privacy more from like a data, how does it protect patients and their data? So that's the sort of differentiation. But yeah, thanks for great question though. I can understand.
Yeah, I guess Lucy, I have one quick question because I don't want to delay
Yeah.
this study because this is where I'm sort of I think the interest is. But in terms of
Mm,
users or people have engaged with resources from that have been produced by Chai and filled out model cards,
mm,
is
mm,
it
mm.
give a sense of like the size and demographics of those companies? Are they larger health AI companies, or is it sort of a spectrum from startups to other? I'm just trying to think in terms of like the burden
Adoption.
on a smaller lean company versus maybe a company that has more staffing and bandwidth, and if you see sort of barriers to participation.
I would actually totally disagree with that in terms of I think the startups in Chai have way more to gain, and so they're really like on this. It takes like an hour or two to do the model card. It's like all information that's like readily
Yeah.
available if you are close to your product teams. And like if you look at the registry when it launches, which is in a month or two, I don't think any of the Amazons and the Googles and the Microsoft tooling is on there because they're like away with the races. They have huge budgets and project lines, etc. So like they probably have less to gain from being seen to be trustworthy and transparent in these model cards. Whereas like if you're an AI doc and you've got 17 approved algorithms, you're not a tiny startup with one person in your garage, but you're like, you've still got customers that you need to win over kind of thing.
Yeah.
So yeah, I would say that the startups are definitely the most engaged with our products and resources because they're the ones who need the kind of marketing of their products to make sure that they can point to Chai to say, hey, we developed everything according to Chai, and hey, health system, who we're trying to sell to, you actually were involved in the work group of Chai, and you said that you believe in responsible AI, and actually we're responsible. So why don't we, get into bed with each other, kind of thing. Like they're very much, yeah, I say like the most active community, definitely, because they have so much to gain from it.
I think there's one more question in chat.
Yes. Who do we blame when AI is working on patients and healthcare? Are there policies protecting the work of AI or the one operating the AI system? Yeah, it's a really good question, Raymond. So there is currently still, I mean, I'm constantly checking, so like there's always rumors that it's going to get axed, but right now there is an OCR, Office of Civil Rights rule, Section 1557 of the Affordable Care Act, that says that any deployer, I think is the word they use, any deployer of AI or sorry, any deployer is actually responsible for the impact and outputs of any tool that they use, and that is including artificial intelligence. And so, as it currently stands, the one operating the AI system is liable for the output of the AI if it is found to be discriminatory. That is obviously with a bias lens. But I would say in general, like, think about in your daily practice when you're using ChatGPT, it is a tool for you to make the decision. Like if you're using it to write an email to your boss, like you are the one writing the email and you're using AI to sort of help you in that process. I would say like that still stands within kind of clinical professions, which is like open evidence is a kind of large language model, ChatGPT, as it were, for doctors. And you're still liable as a person to use that AI in a way that, like, you have to double check. Can't just take what it says as gospel. It might be hallucinating. So I'd say like human in the loop is still the norm when it comes to AI. And so you as a human still have like a right to be, I guess, blamed if you wholly rely on a technology. But it's actually really interesting that you asked that because there's a really live debate happening at the moment with regards to agentic AI. So if people don't know what agentic AI is, it essentially means autonomous AI. So an AI that can automatically fulfill your prescription and send it to you without a human ever having reviewed it. They just look at your um, maybe they've taken your vitals to check that your kind of blood or insulin levels are like at the right level. And they can kind of clearly see that, you're within the range of the prescription. And then they can fulfill that prescription order through supply chain and operations. And then they can actually, dispense that and send it to your house without ever having a human in the loop. There's a company called Doctronic who are doing this today in Utah. And they're in the first phases of this pilot. So we'll see what happens. But like there is a very real reality within the next year or so where AI will not have a human in the loop. And so then that raises a really interesting question. Okay, well, what happens when that prescription has been filled out wrongly? And who am I to blame? Is it, the medical licensing board that sort of like that licensed this AI to do that? Is it the AI company? Is it my, primary care provider that pointed me in there? Like, yeah, like the product of the sort of question of blame and liability is a fascinating one when there's no human in the loop. So I don't have an answer for that, but we'll see as AI becomes, more and more mature. Who is responsible or liable for mitigating bias and responsible AI? So again, yeah, back to this OCR rule, like you are wholly liable for the tools that you use as a healthcare profession, including AI. So you are, Chai or others is a way, if you were to go through a quality assurance process and actually show that, this AI tool that we were using has been through a level of quality assurance. It has been tested on a representative population. You're mitigating the bias, you're showing that you've been through the fair processes and to a reasonable effort, you were under the impression that this AI tool is non-discriminatory. Like that is a process that I think is really important. Clearly, as of now, AI systems is highly biased on many fronts. Perhaps as bias mitigation may improve. Hope. Yes, I agree with that. I think that Chai is not a formal bias mitigation process, but it is an example. If you have gone through the checks and balances, like you could fair and reasonably say that you have been through bias mitigation practices, because a lot of the work that we're doing at CHAI is with fairness and in mind. So yep, that's a really good question as well. Thank you. Right. Okay. And so, by the way, sorry, you mentioned like who is specifically liable. It kind of depends. Like if you're an ambient scribe, or if you're a doctor and you're using an ambient scribe, um, I think you have a duty as a healthcare professional to be checking the output of the work. But if there was something like heinously wrong, you would hope that like your provider system, so if you work for like UMass, for instance, you would hope that they had been through the like procurement decision to make sure that that is a tool that is actually like safe. And so we work at the kind of health system level as well as the individual practitioner level. How does CHAI compare to the FDA's new TDS guidance? Differentiating, how does CHAI compare to the FDA's new CDS guidance? Well, firstly, to say we're not regulatory at all, so anything that the FDA says is right. And CHAI is just like a kind of best practice. So differentiating device and non-device AI recommendations. I'm not quite sure what you mean by the question. Like, how do we compare to the guidance? Like, as in, like, do we agree with it? I'm not sure. Do I guess is the question, do I differentiate device and non-device? Or no, I'm not quite sure what the question is. So sorry if I'm not understanding, but happy to answer that question.
Yeah, maybe we can
But yeah,
hold it to
anything,
the end, Lucy. But I think it's relation to this new designation about like digital like wearables, and if they're making
yeah,
insights on health for like wellness. So like it could be a device that's measuring blood pressure and reporting blood pressure back to you, but if it's not potentially if it's not giving you a clinical determination or telling you to make these adjustments or see, make giving clinical guidance, then it may qualify as a wellness product and not a device
yeah,
from FDA standards, I think is that policy.
100%. But I think the question was like, does CHAI compare to that? Like FDA regulates medical devices, and so it's kind of like an FDA question whether or not they regulate wellness devices in the same way that they would a medical device. So like, does your wearable classify as medical device if they're giving health recommendations? That's very much a kind of FDA question, and we would never get involved with that. All that we would be, I guess, in this context looking at is like, how is that AI like being trained? Is it being trained? All that, and we're again a voluntary process for folks to if you're like a Aura ring or you're a Apple Watch or something, we would hope that they have like responsible AI practices that they're using to develop that AI, so that they have like a diverse training data set, for instance. So that's like the type of interrelation we would have with that guidance. But that guidance is like set in stone, and or at least it's like it will be. So we'll leave the FDA to regulate medical devices. What we do is like best practice for the industry standard. Hope that helps. Okay, so what I did is, so we were very lucky to win a grant from the SCAN Foundation. It was a relatively small planning grant. For those who don't know SCAN Foundation, so the SCAN Health Plan is a big health plan in California. The SCAN Foundation is their kind of associated philanthropy. They are a really incredible philanthropist. I have nothing but good words to say about them. Not only because they funded us, but just because like the process was just really thoughtful, interesting. So they're being a health plan. I guess the population that sort of draws down on their services the most is older adults. Like I think don't quote me on this, but something like the last like 100% or so like I can't remember exactly, but like the last few days of like an older person's life, it's something that like accounts for something like 97% of the other costs. Like the long tail is so long when it comes to older adults, and like caring for older adults is so highly kind of cost consumptive that anything that they can do to understand their population a little bit better, will save them money, will mean that they can care for more people, et cetera, et cetera. So they are very focused on older adults, as I'm sure many people are on this call. And so what did they want? They wanted us to, they had a very broad question. It was a planning grant to go and figure out, like, if they were to follow on a big grant for like millions of dollars to kind of solve the solution, what is the best problem to solve? That was kind of the question. What is the best problem to solve within older adults? Why does AI not work better for older adults? That was like a very, very broad question. They just said, go and figure out the problem to solve here. So obviously, like me being a kind of problem-solving generalist, I found this like a fascinating like process in itself. I'm happy to talk through the process, but I went off and just read papers. It's like what my research training told me to go do. So I read about 120 papers, which is not that much when you think about a systematic review, but it was like a sort of finger in the air, what's going on. And I looked at 36 longitudinal data sets that exist from around the world. So they might be state longitudinal data sets looking at kind of retirement studies. They might be nations. There's like an amazing one in Japan or South Korea or China. There's like all sorts of, I think it's called Charles, if you want to look at one up, China Health Aging Related Data Set or something, I think it stands for. But it's an amazing data set looking at, vast numbers of populations of a country or populations of a state, and how their data is being kind of logged. And what I was looking at is like, depending on which state you're looking at, or within the US or even in other countries, like older adults, there is not a unified understanding of who classifies as old. Is it 60? Is it 65? Is it 85? Like everyone classifies older adults as old. But they don't have like, there's like high kind of disagreement in terms of like when you become old. And if you think about you on the kind of eve of your 60th birthday, you don't suddenly inherit new in sort of like characteristics when you turn 60. But a lot of like, I guess, aging data sets are looking at you as though you do, and they're looking at like quite a heterogeneous group. So they think that like a group of 60-year-olds will share a lot of the same qualities, which we know that's not true. Like an older adult in Upper West Side in New York versus an older adult in kind of Appalachian mountains, like they're going to share relatively almost zero like qualities. They might have completely different lifestyles that mean that they have all different genetics. And so I think there's just like a problem with older adults as a kind of terminology, because it just means that they're like highly sort of misunderstood. And I think it's also really important to say like older adults are very underrepresented in data sets, especially those at the top. So if an AI model is being used on a group of patients and some of them are old, the likelihood of them being trained on an older adult is like really, really, really unlikely. So they did an Apple Watch study, and also like these, Oura rings, and like because they'd never been trained or tested on older adults, if you were an older adult and you were wearing one of these, they just like no data came up at all, because they like the skin was too thin, or the ring didn't fit or something like that. Like there's just like a highly, I guess, missing group within these training data sets. Data is really fragmented. So, if you're an older adult, you might not go into clinical settings that often. And actually behavioral and social determinants of health might be like more important than actually the clinical data. So the data is really all over the place. As I said about the standards, there's a really like poorly understood sort of definitions for age. And also, there's these AI models often assume that like, as I say, if you're old, you are old and you share lots of characteristics with other old people, when actually there is obviously high diversity within older adults. So these are some of the problems I was starting to see. And then I started to speak to people, Lily being one of them, and maybe other people on this call. I can't see who's on the call, but I went and spoke to about 30 different individuals coming from about 25 organizations. Again, not everyone in the space at all, just wanting to get a kind of finger in the air of what was going on. And actually, for me to understand how AI could serve older adults better, we started to categorize into kind of 5 areas that if Scan Foundation wanted to fund a follow-on report or follow-on kind of grant, these are sort of 5 of the areas that they could sort of start with. And I guess first and foremost was this behavioral phenotyping. So could you actually create, rather than older adults being a sort of one size fits all term, could you actually split that into 12, 20, 50 phenotype groups to say, high exercise, urban environment, female, who has never suffered from cancer or anything like that. Like, start to create these like phenotype groups where actually you, rather than having this massive data set of like 65 million older adults, you might have smaller group data sets of like categorized people. And therefore, if you're doing training, you could actually train it on like these 50 phenotype groups rather than doing it on one just amorphous blob of older adults. Because if you do it on a like more specific patient populations, then it's more likely that they're going to work on those different people. So that was kind of one thing that emerged. Then there's this kind of common data model, which is like, I guess, I'm not going to go into too much detail about this, but like there is I guess, like some sort of standards to say that like actually you could create like an aging specific data model, and actually create like a sort of data access group. So, like let's say UMass has the EHR's electronic health records of 55 million older adults. Could you actually create some kind of data standards for how those older adults could be kind of used in training data sets? So it's a kind of like mapping exercise between training data sets and the models that need to be used to try and kind of create that common data model. Then we thought, like, could we actually also just like as a marketing exercise, because there are so few organizations actually building AI for older adults. And could we actually do like a bit of a data challenge to say, like, could we, a little bit like the AgeTech Collaborative, if you know them, could we do something to actually show what AI could do for older adults? Maybe they're looking at kind of risk models for falls, like falls prevention models, or maybe there's, lifestyle behavioral AI, or maybe there's actually like loneliness as a big, or dementia as a big sort of kind of problem area for older adults, because they're like AI that could be used to kind of try and improve that. And actually kind of bring forward more practical solutions. Could Scan Foundation fund this kind of challenge? Or even could they fund like data collection practices that would, then make AI, getting trained better? And then also, could we actually, this is something that Chai does like a lot of thinking around, is this model validation and testing aspect. Could we actually go through a process of evaluating AI models in community settings, so actually in care homes or in places at home, for effectiveness on older adults, and actually, fund the evaluation of these AI models on real patients who are old. And then Chai, what it does best is it develops playbooks, it develops best practice. Could we actually also, how, if older adults need to be more included in the design of these AI models or robots or whatever's being used upon them, how do we create this kind of playbook to do that with older adult patients at the center? And how do people kind of access these people in the first place? So these are the sort of 5 strands of the research. The research happened over a few months. As I said, 120 papers, about 30 or 40 interviews and focus groups. This is such a sort of, I guess, one of the main reasons that I wanted to kind of come to you guys is to hear about like some of the feedback. Does this hit home? Do you agree? Like, are there other things that like could be done? And actually, also, are there any companies or kind of philanthropies even that are wanting to actually take this further? Because I got so interested in this space, and every conversation I had just like made me more and more interested. And I'd love to pursue this research further with any of you guys, or take this to a grantor and actually move forwards with one of the grants. The Scan Foundation decided not to go ahead with the second phase of this grant, not because of anything we did. They just had a reorientation to their funding, and so didn't have any follow-on funding for this, but that is fair and justifiable. So anyway, I will probably stop there because we've only got 10 minutes left and I've talked so much. I'd love to hear, qualities. Oh yeah, thanks Preeti for sharing, Charles. That's great. Yeah, I would love to hear from you guys on, what, if any, of this kind of hits home for you? What is interesting? What is something you've learned? Are there any follow-on opportunities to work together on this, or just even have another chat? I would love to hear more. So I'm going to stop sharing. I think this is the last one. Oh yeah, I love this. I found this in an article literally just as I was doing the research project, which is a future of aging with dignity, support, and connection is within reach if we build it together with those it's meant to serve at the very heart of the design. I found that in an article and just thought that was really helps us orient like why we're doing this work. Like AI should be developed with patients at the center, and older adults are no different. They might be harder to reach, but reaching them is still a pursuit, a worthy pursuit. Cool. So I'm going to stop there. Hopefully people are still listening, and yeah, I'd love to hear thoughts and reactions from those on the group. I'm going to call out Lily just because she's here. But Lily, did I well represent what we spoke about? Did you have any thoughts and reflections from the conversations we had in the focus groups, or having a bit of time between then and now? Have you thought any more about how AI could serve folks like you're a caregiver, folks like you look after better?
Thank you. First, mic drop. That was awesome, Lucy. First, if I may introduce myself, I am Lily Liu, based in Washington, D.C., and part of the A2 Collective AITC, representing the Caregiver Stakeholder Council with Johns Hopkins. And there is also the UMass one and the UPenn. Shout out to Professor Paquette and his team for the excellent Frailty Conference that just took place. If you could put maybe the link, Dr. Paquette or others, if you have a chance to view it, please do, because it sort of resonates with me. And forgive me for not coming on video. It's winter hat hair. The issue is, how do we involve caregivers, family caregivers early on? So if anybody's interested, I took the lead in with my colleague who's actually here, Susan, who is part of the UPenn one. And we did 2 articles for the UPenn AITC newsletter about involving caregivers, the patients, the folks who are going through the medical system as early as possible in the design process. So the point that you have made, Lucy, is that it's very important to have stakeholders of all types at the table. And by being able to participate in that workshop series and now seeing the final report, kudos to you all, because you understand how important it is to involve the caregivers. So I will, especially since we know on here are such brilliant researchers, Dr. Deepak, others who are in computer science and electrical engineering and data science, but then having us as part of that whole design and development process. Very honored and respect that you have us at the table. Thank you.
I think there's a question from Susan in the chat. Says, folks engagement farther upstream. Have you looked at UK NICA's voice organization of engaging elder folks in innovation?
Have I looked at Nika's voice? I don't know if that's pretty honest, because I don't think, is it nice? You mean, or I've not heard of Nika as an organization, but maybe that's
NICA. I don't know if maybe Susan knows more, but
Nika, National Innovation Center Aging. So I didn't know that existed. So that is really good. Thank you for letting me know. I did. We looked at like, I'm trying to think if I actually looked at them. I don't think so. I think I looked at like All of Us, etc. from the US, and I think there's like a I'm forgetting the name now. A study that is, I think it's called Our Future or Our Future Health, OFH, which is getting like 5 million patients data in for research within the UK. So I didn't look at Nika, it actually looks like it's an aging specific version, but I was kind of more coming at it, which is like where like are older adults like fairly represented in kind of large scale data sets? And my answer was quickly no. So yeah, completely agree with, needing to engage folks earlier upstream. That was kind of one of the recommendations, was to kind of include patient-centered design. So folks like Unica could be like one of the ways to do that. And it sounds like, so I'll have to check them out, but thank you for letting me know. Yeah, great. Is that what you meant? Sorry, I don't know if you meant, Susan, if there was anything else to say on that, but yeah, maybe that's a great thing to look at. Great, cool.
So Lucy, thank you
It
for
is
a great talk. This is Deepak. So I unfortunately I missed the last 10 minutes because I had to step out, but I think to your to the pursuing this work further, you know, the ITC program has each of the centers has about 40 or so pilots at this point. And so
mm,
I think one of the interesting things is it just gives you a very diverse set of directions that AI and technology can take, right? Lots of different
mhm,
ways in which technology and AI can be used. Lots of different challenges. Each one has a very different challenges associated with it. Because when you think about the types of sensors, the types of data streams um, that each of these pilots brings to bear, it's very different. Like some of them are cameras in the home and that have privacy implications, obviously. You might camouflage
mm,
and AI might be processing those data sets, the data streams, and it could be locally processed and discarded, but that's a different set of capabilities, right?
mm,
Set of challenges. And I think one of the challenges, in this space for the aging space, in as you use technologies for aging, is that the data streams are so diverse, right? We are not
mm.
just talking
Yes.
about LLM like text data or EHR like data sets, right? We are talking about home data sets. In our center, a lot of the pilots are in the home setting. So we're talking about at-home data sets, which could be any number of imaging type of data, audio data, it's wearable data, and some of those we don't yet know how people might like what you can infer from that, what you cannot do. So the challenges involved are with multimodal data streams. And so I think that's one of the challenge. And I think the other dimension which often comes up is that when we think about people with cognitive decline, what does it even mean? When you engage with them and when you talk about responsible AI in the context of engaging with somebody, uh, you know, in various stages of decline, like how would we even think about that? Um, what would a model card look like in that context? Some of it is unclear. Anyway, I just wanted to say there's a lot of, if you're interested in taking a look at some of
Yeah.
the space of pilots and then thinking through this further, I think there'd be a lot of interest from our centers.
Yeah, absolutely. I think it's about like shining a light on best practice. So which of those pilots are actually doing things, how have they been able to access the patient group in order to like, fully bake that into the development of AI? Great. And then also how have they been able to integrate the multiple different data sources from wearables, from sensors, from voice agents, from all these different things in order to like, how does that go back into the clinical pathway? All of those like questions. So like best practice, fascinating, but also is there something that Chai can do given its background in like connecting or at least like sort of aggregating a voice? Could we be like if there's best practice that's being done on how to integrate multimodal data, like how can Chai get that out? Like that's kind of what we do really well is like because of our network, because of how we develop things, we're really good at sort of publicizing best practice. So yeah, I'd love to work with you and with Dr. Paquette on like how to shine a light on all the best practices going on within your pilots at AITC, because I think we're seeing, I'm sure you're probably seeing it on a very like person to person or company to person ratio, and we want to get that as the industry standard so that no one else is developing AI other than best practice.
Yeah, I just
So
wanted to last point. I know we're at time,
yeah.
but we just had a workshop on frailty like on Friday, and as Lily mentioned, and
Mm.
something like that in this context would make with Chai would probably make a lot of sense. So we can follow up.
Yep. So thanks, Deepak, and thanks, Lucy. I just wanted to highlight that next month we have a talk coming from Professor Fang Yu from ASU Roybal Center. And I think this is really relevant and on topic to the point that Deepak made about sort of what do we, technology with individuals with cognitive impairment and sort of the question about accessing validation and appropriately validating technologies. So their center is focused specifically on developing and testing in the NIH stage model, mechanism-driven technology interventions in response for specifically older adults living alone with cognitive decline. So that it should be a good talk to sort of continue on with this trajectory. So if Lucy, if you can make that, it might be another good sort of group to connect with.
Yeah. Oh, 100%. That sounds great.
Yeah.
Well, look, I think we're at time. So, look, thank you so much. I'm going to pop my email in the chat if people want to talk to me about any of this, or just, have something interesting they want to share, please let me know. But otherwise, just thank you so much for having me. Really committed to learning more in the space, and so grateful for the opportunity to tell you about what I've learned and how we do things. And then, hopefully this is the start of more conversations.
Alrighty. Yep. Thank you, Lucy.
Great.
Thank you,
Thanks
everyone.
so much.